Hello. So this talk is about advances in intracorneal ring segments for treating corneal ectatic diseases. This is a very important part of my clinical practice today, and I think it's maybe a good idea for you to consider this option along with cross-linking. These are my financial disclosures, including Oculus and Medifacus. I would start this talk remembering that when I did my training, we only had penetrating keratoplasty, and I learned that from Dr. Civental in Brazil. Now we have DALK, but beyond corneal transplant, we have many options. So we broke we have a paradigm shift. So this paradigm shift is important that you understand the paradox. The paradox is related to when and why to do surgery. Because if you need surgery, I think you should do as soon as possible. But if you don't need surgery, I think we should reconsider the whys for indicating procedures. And the question is when to indicate surgery, when you need surgery. Basically to rehabilitate vision, when the patient does not have good vision with glasses or contact lenses, that's the classic indication. But now with the advance of cross-linking, we have halting ectasia progression as a very important concern. But one of the main points here is that this is still kind of paradoxical because we do surface ablation in some cases of mild keratoconus, but keratoconus surgery should not be a refractive procedure. And the therapeutic procedure should be defined as a procedure to rehabilitate vision. The success is measured by distance correct vision and not needing a keratoplasty. While elective procedure, the procedure would be considered as a success if the patient is happy and satisfied, the quality of vision has improved, and we do measure uncorrected vision. So it's important to understand and set proper expectations so that we can get higher levels of success. We cannot discuss corneal rings for keratoconus without mentioning the great work by the past Professor Colin from France, and also my colleague and friend from Brazil, Paulo Ferrara. And those two were the first ones to indicate corneal ring segments for ectatic diseases. The classic indication was to improve refractive error, since the Barraquet work considering the law of thickness to add tissue in the periphery. So the Brazilian ring segment history is nicely summarized in the iChannel from my colleague Alexandre Paratella, and we have Ricardo Guimarães, Walter Nozé, and of course Paulo Ferrara here telling our story. Implantation technique, of course, we have the manual dissection. I think any surgeon who wants to do corneal ring segments implantation should master it, but it's the only indication of femtosecond laser, any application of femtosecond laser technology that I would say it's a mandatory to use a femtosecond laser in my practice because the clinical results are better. And it was very nicely done by my colleague Tiago Monteiro from Portugal, who did the study comparing manual and femtosecond laser dissection, and we had safer and more efficient results with a femtosecond laser. The ring segment, we have to understand the idea of the flattening procedure with the adding tissue in the periphery. If you add more tissue, you have more flattening. If you add more tissue closer to the center, you also will have more flattening. That's a very important concept from Blatskaya, that the radius from the optical zone that you try to create, if you try to increase it, you have less flattening. We have defined nomograms, but one of the things that I would say I would have a huge expectations and promise is the use of biomechanical data. First with fine element modeling, and of course using real in vivo biomechanical measurements for defining prognosis and setting the best way of planning the ring segment. There is a secondary effect which is related to corneal modulation of the epithelial thickness layer. This is a case that we published as a unilateral ectasia. The fellow eye had everything normal done on the study by Dan Ringstein on epithelial thickness in the left eye. Everything is normal. We referred to this case many times for the concept of unilateral ectasia to biomechanical impact on the right eye. This right eye had a great result, and this great result was even getting better and better based on this hyperplasia, which is nicely seen also on the high-frequency ultrasound, this epithelial thickness hyperplasia that you can see here. And interestingly, the ring segments are reversible and adjustable. This is a patient that I did put 2 rings, and there was a huge overcorrection the first day. So just go back to the OR, and with an inverted Sinskey Rook, you just enter very easily in the tunnel and just grasp it and remove the ring segment. And this patient did much better. Then you see here the effect immediately and about a few months. It's also adjustable when you consider if you push the ring segment a little forward. This was first demonstrated by my friend Federico Guerra, that showed to me this case, and I really saw we can do that at this slit lamp. And today I see the first day and first week, and eventually I push through the incision at this slit lamp. I don't need to take the patient to the OR, but you see the nice effect that you have. We have an evolution on the ring segment options, and it allows for customization. The concept is that a shorter arc would decrease the cylinder and less the corneal power. Longer arc, you have less effect on the cylinder, but more effect on the spherical correction corneal power. But when you consider the longer arc, and you can have modulated over like a thin, thick, and thin, or vice versa, you have good ideas. And this is a very easily implementation if you master. It's very straightforward. You can do that at the femtosecond laser microscope with FS200, and of course with the Visumax, it's even with a better microscope. So that's something you should consider for eventually larger corrections. And today, I would say still a little bit of art. Sometimes I push it through the incision and leave it like that. But today, with a 320, I prefer to leave equidistance from the incision. And this can give you very nice results. And there are some people that would say the limits for rings would based on keratometry. I would say it's a mistake, but we need to judge every patient and consider patient education as heroic procedures for more advanced cases. The asymmetric rings, for the thickness progression rings, is one of the most important advances that we have today. And this is a case that presented with asymmetric keratoconus. The fellow eye had unquestionable form-fruit keratoconus, and this eye just needs to have follow-up. But the right eye, even though we had a wavefront-guided refraction, wavefront-adjusted refraction, the anisometropy of the patient lead to the ring segment, and you see a very nice result with a uncorrected vision of 20/30 improving to 20/25, about 3 months with a stable result with over a year. We published the intercorneal ring segment with asymmetric progressive thickness profile, along with some colleagues, Efren Kosku-7 and Francisco Chances de Leon from Mexico and from Turkey. Also, we can combine ring segments with transepithelial cross-linking. That's one of the techniques that I really like to use when the cornea is very weak based on corneal biomechanics. And this is one of the first cases we did, and we didn't have much of fancy work on the corvus, but you can see the Scheinflug image can demonstrate nicely the central effect of cross-linking based on the demarcation line, which you can see at the slit lamp, you can see at the Scheinflug imaging, and of course in tomography. This can be related to the intrastromal application of riboflavin, very nice work by Seiler, father and son, that probably is a very good alternative for epi-on cross-linking. So when you think about the role of cross-linking for corneal ectasia, it's a fundamental for my practice. Surgery for ectasia, we should be keen on indicating when, how, and why to do it. It's a revolution in evolution. We have to understand multimodal imaging, individualized medicine. Again, applied ancient and artificial intelligence. Patient education and the role of Violet June is very important because we have to set patient expectations so that they understand why we are indicating surgery. The evolution of corneal ring segments would go probably to the biological ring segments. Is nice work by Susan Jacobs. So the future is really promising for keratoconus treatment, and refractive surgery is a very important part of this evolution. So thank you very much again for your kind attention.